All right, we'll start. We're recording for folks who are unable to make it at this time. Good morning. I'm Ann Lenson with the U.S. MEF2C Foundation. Welcome to this informal interactive discussion on hypotonia. This is a very common condition for MEF2C patients. Personally, I'm very excited to hear about what part of the brain this is coming from and therapeutic practice in this area. Joining us today is Stella Jeong, a fellow patient advocate, a member of our therapeutic advisory board, and physical therapist. And Stella is here to share valuable insights on this condition. The call is being recorded. Please raise your hand to join the discussion and ask any questions that you may have.
Awesome. Thank you, Anne. Thank you for the introduction. Um, Here, I will start sharing my PowerPoint here as well. All right, perfect. Well, hi everyone. Good morning. First of all, welcome. I really appreciate you all being here, especially this Saturday morning. I know it's a busy time of the year and how precious time is. Um, and my name is again Stella Jeong. I'm the physical therapist specializing in pediatrics in school-based setting. I have a daughter with MEF2C myself. So today I have my presentation here called Understanding and Supporting Gross Motor Development in MEF2C related disorder. Um, Perfect. So, a little introduction. As I said, I'm a school-based physical therapist in Chicago Public Schools, which I think is third largest school district in US. And yesterday was actually our last day of school, so busy times. I think I just finished my fifth school year there. Um, Anyways, here's the photo of myself and my husband Ben, and there's Ara. She actually just turned 18 months old, so she's exactly a year and a half. I feel like time really flies. And here is my cat Lemon, and then there's my another cat Butter as well. So that's our little family. Um, Before we go into objectives, I just want to say I know this is you guys are just like living out your um busy Saturday morning. So if you have to like step out or anything and like come back, feel free to do so. I'll be just here talking, and if you have any questions, like Ann said, you can raise your hand or you can comment on the chat section. And I do have Q&A session at the end of the presentation, so we can go over it then together. Okay. So objectives for today's presentation is that first we'll go over the understanding the term low muscle tone and its functional impact on posture, movements, and daily activities. And then we'll go over the tips and advice on practicing new skills at home so that you can actually take home some advices. And then we can also go over some helpful practice models that you can apply at home setting. And then finally, I would like to also go over therapy sessions through IEP and 504 plan, which would be US specific because I'm practicing as PT in a US setting as well. All right. And little disclaimer, I would like to point out that everything that I'm presenting today is only intended for educational and informational purposes only, and that it is not a substitute of professional medical advice. I think the most valuable information can come from your doctors and your therapist because they really know your child the best. And, plan of care really is supposed to be individualized. So all the information that I'm presenting today is more of a good to know information that you can take home. All right. And here I wanted to share what Ara and I have been working on recently for her gross motor development, which actually I worked on this presentation more in April. So back then she was working more on independent standing and walking with her walker. Here I can try to play the video here. Let's see. So there she is walking with her walker at her local playground. Um, and now that it's June, we are working more on independent walking skill. So she's able to walk short distances, so like 10 to 15 steps on her own. And she walks pretty well with just like me holding onto her one hand as well. And yeah, she uses her SMOs, of course, when she's walking. Her overall endurance is pretty low, which is expected, but we're still working on that longer distance walking as well with her walker. So we'll log out the walker into her playground or the park, and then we kind of make her practice more longer distance walking as well. All right, so that's where we're at. And I just wanted to share some photos from my work. So, as a school-based physical therapist, I do work with pre-K through high school students, actually all the way up to age of 22, because I also work in a post-high school transitional center. So, yeah, I get to work with a lot of different diagnoses, like different diagnosis, demographics, and just really wide range of gross motor skills that I get to work with. And I say that some of the common conditions that I see at work are obviously just, classic developmental delay, a lot of autism, Down syndrome, cerebral palsy, and many rare genetic conditions, very different ones. Kind of like MEF2Cs, a lot of them no one really knows about. And of course, at the school, I'm helping them with all the adaptive equipment. I have to help them navigate the school environment, as seen on the photo there of student going down the stairs. I make sure that they are participating meaningfully in PE and recess with their peers. So it's really a lot of fun things at my work. Yeah, so we'll go into our low muscle tone section. And I thought this photo of Ara doing the splits was very appropriate when kind of visualizing the low muscle tone. Okay, so low muscle tone. First, we have to identify what muscle tone it is by itself. So not high, not low, but just muscle tone itself. So there really is not one solid definition to it, but traditionally it is defined as the tension in the relaxed muscles. So if I was to ask someone to relax their arms, and if I try to move it through its passive range of motion, I would be kind of examining the person's muscle tone by the level of resistance that I'm feeling. Um, and that second paragraph, there's slightly newer concept of muscle tone. And you can kind of glance over it. I'm not going to read it because there's a lot of big words in there, but what it basically means is that muscle tone itself, yes, it can be measured at a muscular level, but like by me yanking at someone's arm, so in a muscular level, yes, it exists, but basically, it can be something bigger. So muscle tone, which is an adaptive functioning and communication between our brain and muscle, it highly impacts our postural control. So how you stand up, how you're controlling overall posture, and other movements as well. So it kind of expands on this idea of muscle tone only existing in your muscular level. But really, it really is a bigger connection between the motor cells and the upper commands that's coming from your central nervous system. So, for example, by upper commands, it could, be coming from our brain. So the cortex, basal ganglia, cerebellum, brainstem, spinal cord, and then finally it reaching down to the muscle spindle in the muscle. Um, and applying this to MEF2C community, we already know that MEF2C gene is crucial for developing our central nervous system. So the differentiation and refinement of different neural connections. So it makes sense that the muscle tone would be impacted with MEF2C disorder. Because it is something that happens between the brain and the muscle. And we already know in that case, it is most likely going to present as hypotonia at first, but we have varying, numbers of cases where hypotonia and hypertonia is both reported. Okay, so speaking of hypotonia and hypertonia, um, I think the problem with muscle tone can be so low or high. So low means hypotonia and high means hypertonia. We can go over the hypertonia first. So meaning it's a high tone, so the resistance is high, and the cause is almost always from the damaged central nervous system, or what we call an upper motor neuron system. So something like cerebral palsy or any kind of stroke, MS. There will be some kind of a loss of inhibitory signal from the brain to kind of turn off the muscle activity. So joints movements are going to be very loaded and labored and almost locked with hypertonia. And hypotonia means that resistance is low. So the movement is going to look flappy and loose. The origin of hypotonia seems to be a lot more complex. So as it can come from anywhere from central or peripheral level, so brain or in the muscle, but it can also be a result of a genetic influence, so kind of like MEF2C disorder. So some examples would be Down syndrome, muscular atrophy, cerebellar disorders, things like that. And I think it's really important to note that there is a poor quality signals between brain and the muscle when we're talking about hypotonia specifically. Um, Going into my third point, I think another really common misconceptions that we hear about hypotonia is that low muscle tone and muscle weakness go kind of hand in hand, or maybe it's like the same thing in general. They are actually two very different things. So hypotonia, like we said, is a poor quality signals between brain and the muscles, resulting in flappy posture and muscular control. But muscle weakness is, on the other hand, it's more strictly how muscle can generate its force at a muscular level. So, like when I'm changing our diaper, she is rolling all over, she's kicking me, so I know the strength is there, right? Sometimes you have experiences where like, wow, my kid is like really strong, but how can she like not sit up on her own? So those are the kind of different experiences of like low muscle tone versus muscle strength in contrary. So muscle weaknesses happens more in the muscular level, and then hypotonia is more kind of like everything connecting between brain and the muscle. And MEF2C, um, there's some current research studies suggesting that yes, it regulates how we develop our neuronal system and plasticity. So it's talking about the connection, but it also plays a role in very early muscle development itself as well. So suggesting that it can directly play a role in muscular development. It could impact muscle strength as well, per theory, but clinically, they are saying that it primarily presents as symptoms as neural developmental disorder. So rather than a primary myopathy, meaning decreased muscle strength, it really more is it's gonna clinically come more as a low muscle tone. Okay, so we can kind of go over these pictures on this slide. So I have some helpful visuals here. So first, imagine this steel jointed robot so that is connected with a bunch of rubber band system. So the rubber band is holding the two parts together. And imagine that rubber bands in between its joints are very loose and stretched out. And then imagine how that stretched out rubber bands would impact its movement when they're trying to move. So it will probably look really sluggish, less controlled, and fine, refined movement is going to be more difficult because that rubber band is just not tight enough. So I think when we apply that visual to our kiddos, you can kind of expect them to also have that sluggish, floppy movements. And although we cannot visually see that brain to muscle connection with our own eyes, I think we can kind of imagine one as like an unpaved road versus like a high traffic 4-lane highway system. So if you're a neurotypical person, the connection between your brain and muscle will be that highway system, right? But with our kiddos who is struggling to make the neuronal connections, it can look more like that unpaved road that is less cars going by and the roads are bumpy. So there may be more obstacles to kind of deliver the information back and forth. But I think it's important to note that even though the condition and quality of the roads might be not, not as good as the highway system, the more the cars are traveling, it is going to pave down that road a little bit. So it will, with practice and repetition, it is going to smooth out that road, which is how we see that our kids really benefit from the repetition and like blocked practice model. Okay, so we can now talk about the functional impact of the low muscle tone. Um, the posture is something that low muscle tone impacts probably in the greatest level. So classically in the clinic, you will see this belly out, arched back posture due to the low core engagement. You also see some hyperextended knee and feet maybe wide apart when they're trying to stand for their balance. And really, it's their body just trying to more stability because they don't feel secure with just their muscular system. This also can look like their high pronation level in their ankles and the preference to W sitting as well. So with low tone, because you are not really able to rely on your muscles to be the stable one, so what I tend to see is that they tend to use that bone to bone, that hard joint and feel for security rather than the muscle kind of like holding the fort down. It can be really like max stretched out ligament and bone that's working more than the muscle. So that's why we see like W sitting or them kind of arching their back. And in the school, if you see that blue chair there, I see that students with low tone also benefits a lot from like adaptive chairs. That one is called the compass chair from Riften. So the chairs that has high back support, the armrest support, and the wide leg can be really helpful for their security of their body. And also, when their head control is impacted by the low muscle tone, the more secure headrest piece can also stabilize the neck better as well. All right, so if you have any questions about the hypotonia so far, you can jot that down on the chat section and then we can go over at the end together. Um, and then we'll now be moving on to tips and advice on practicing new skills at home. And that's my husband trying to practice walking with my daughter at the playground. All right. So practicing new skills at home. First, oh, yes, Anne. Oh, you're muted.
I had a quick question
Yeah.
on balance. So, some of
Mm-hmm.
the things that we did with our son at the very beginning were climbing up stairs. He needed a lot of incentive to do that, like crawling upstairs. He would turn a page to crawl up another stair. I actually can't even like remember how we got him to do something so difficult at the beginning,
Mm-hmm.
but he was climbing up two flights of stairs. And then things like now when he's older, sitting on a ball to activate the core. What about
Yes.
things like that for hypotonia? So really a large focus on the core,
Yeah.
activating the core at whatever age level experience is most relevant.
I think age is little bit out of the picture for me because with MEF2C disorder, where they are at gross motor skill, doesn't it's not always age appropriate. So like they might be 7 but still working on independent sitting, or they might be 2 and they might still be working on walking. So I think there's a lot of variability and range. But so I can't say like age specific things, but you're right because the low muscle tone is impacting that postural control the most, and your core muscles, so your abs and your back extensor muscles, those are the muscles that work the most when you're talking about someone's posture. Um, yeah, sitting and bouncing on the ball, definitely great activity for your ball or your core engagement. So anything like a hip, like that large hip muscle, glute, and core and back exercises is going to be really helpful for improving that low muscle tone or their adaptive functioning skills. And I think I'm gonna go into a little bit more of how you can like support these skills a little bit more as I go through this section, if that helps. Did I answer your question?
Yep. And then I just had a quick, because I'm very interested in hypertonia as well.
Hmm.
And that I see as more relatable to cerebral palsy.
Yes.
And our kids, many of them have both, which
Mhm.
makes daily living skills exceptionally difficult if you cannot easily put your foot up on your lap to take off your shoe and your sock. And I just wanted to ask, we have a physical therapist. I don't know if she's on the call yet, but we're always wondering, we do a lot of stretching for the hypertonia.
Yes.
And I think there are Botox treatments
Mhm.
that could be used
Yes.
for that. So that's more in the realm of cerebral palsy. It's a different part of the brain. And I
Hmm.
was just wondering, it's such a bizarre mix to have.
Yes.
So people always just assume it's just all about hypotonia in our patients, but many of them have hypertonia as well. And we do have a subset of patients with cerebral palsy type phenotype. So yeah, I was just kind of wondering. So that's I read your presentation prior, and I saw that they're coming from two parts of the brain. And do you have any tips on how to treat this hypertonia, this lack of flexibility, because it's such a huge impediment in daily living, helping to care for yourself?
Yeah. Hypertonia, in a way, it can be a little more tricky when it comes to treatment because kind of like you said, to really reverse the effect of like a true hypertonic muscle, like Botox injections, or sometimes they will go through some kind of procedures of like tendon lengthening or things like that to really reverse the effect. I think best thing that we can do at home level with hypertonia is that consistent movement. So even though the patient himself may not be able to activate that range of motion, someone constantly going through that range of motion still sends up that signal to the brain like, hey, I am moving. So it is still impacting their proprioceptive system in their body. And really, it is kind of like MS, you want to maintain what you have can be more of a realistic goal when you have a hypertonia. So, because as they get older or as they get bigger, the in a clinical level, the hypertonia can look worse as it goes down the road. I think just like maintaining where it's at by stretching, going through that passive range of motion so they don't lose more function down the road, I think is what physical therapists focus mostly on when we're working on hypertonia.
Could these treatments be relatable to treatments for cerebral palsy?
Yeah, you mean just like what I said about hypertonia?
Yeah.
Yeah, that is this case for cerebral palsy or like post-stroke patients as well. I think, but with repetition, yes, you can gain some functioning back. And it is nice to know that a lot of these hypertonic causing diagnoses are not always progressive. So really like strengthening and maintaining the function that you have now, I think is probably the best bet.
Mhm. Thank you.
Yeah. hmm Um, so back to practicing new skills at home. Kind of like I just said, with MEF2C, we have a wide variety of gross motor skills of where each child might be at. So one child may be practicing sitting, or other child may be practicing standing at a very different time of their life. So I just want to point out that yes, practicing new gross motor skills at home is very, very difficult. There's a lot of factors that add to this, so such as low motivation, which is something that I also struggle with, ARA, and the short attention span. A lot of kiddos who has also additional autism diagnosis, there can be that autistic behaviors that you can see. And it is difficult for them to follow that 1 to 2 step directions if it is a verbal direction. And of course, there are just like so many skills that you have to work on just outside of gross motor too, but you have to work on their speech, fine motor, their feeding, and all of these above. As a parent, it is a lot of things. So the tips that I'm going to focus on next few slides is something that you can just take home and focus on at a very with like hopefully the minimal effort from you as much as possible. Before we go into those actual tips, I just want to say it again, every child is unique and different. Um, so there are a lot of research and data supporting very different models of learning with autism or neurodevelopmental disorder. But obviously, there is not a specific research out there that is, just MEF2C disorder, unfortunately. But we can kind of imply some takeaways from this general research out there. So we know that early learners benefit from repetitive, blocked practice model and a low variability or predictable models when they're learning a new skill for the first time. And there are many ways to reach the true generations and integration of the skill, meaning like they can now perform the skill, like they have mastered it, and then they can now perform it whenever and wherever throughout their everyday life. To reach that level, there unfortunately is not just one magic way for everyone to take on. That's just not how our brain works. So we have to kind of use very different models of learning to see what works the best with our child. Okay, so first, I think the biggest advice that I would say to any mom or dad who is supporting low tone kiddos or MEF2C kiddos would be really closely observe what your physical therapist or occupational therapists are, how they're supporting your child during the session. Um, because their hand placement, we go through 3 years of grad school just to learn really about like how we can best support this kid and then how we can slowly retract that assistance so they can gain more independence, right? So like I said, that our center of mass and gravity all is in our core. So that core muscular structure and your back. So your pelvis really is going to be the place where you can help them most. So when Ara was first starting to walk, my hands were always wrapped around her pelvis. And even though I am not helping her to, move through the leg one by one, me helping to kind of reinforce the use of those big muscles at the pelvis level would just like help her to take that more independent stepping, although I'm not directly helping her. So at the pelvis level, it would be the definitely the most supportive assistance that you can give. And then you kind of try to slowly go away from that point. So when she's walking, and I feel like she's walking actually really better with me holding onto her pelvis. So then I'm going to move on to maybe holding onto her knees next, and then the ankles. And then maybe just like a handheld, and then a finger held. So as you go away from the center of the body, your child has to work more essentially. And it is really important to slowly gain that independence. So even if your child like does great with certain type of support, it is important that you try to progress that physical assistance from away from their center of gravity so they can do the most that they can do. And um, that method works most of like standing or weight bearing postures. But if they're working on tummy timing or even just like holding their head up, um, some of the beneficial other assistance point is that wrapping around their elbow level so it's not sliding out. And it kind of like prompts them to really activate their arms and core to bring their head up as well. So just kind of really watch what your kids do during the therapy sessions and how the therapists are helping your child so you can kind of replicate it at home as well. So at home, this model really works well for me as a working mom who, Ara gets 4 different types of therapies every week. So first, I'll pick one skill to focus on that week. So whether it's independent standing or dynamic reaching, and then I'll try to add an action before or after. So if it's standing goal, I am going to have her transfer from floor to standing. That way I am kind of making the most bucks out of its money. It's not just independent standing, but I'm actually targeting kind of sneaking in another skill at the time to work on. So if it's dynamic reaching, not just reaching, but I'm going to help them to put it into the basket after reaching. So it's more of a one complete task. And I like to do this like 30 minutes a day, kind of repeating the same thing over and over because that repetition really helps. And I kind of try to also sprinkle random times throughout the day as much as I can. So there's that random practice model built into their lives as well. And I can't tell if that hand is new or not.
Yeah, it's new. Oh, yes. Yeah, I just had a comment on physical prompting because
Yeah.
you mentioned prompting. And I know that as I don't remember doing it as much when my son was younger, but but now that he's older, we do it much more, and it's been a huge help in terms of, showing him which leg he needs. So now we're working on independently going up and down the stairs without using the handrail. And when we first started, I thought, oh my God, we're never going to accomplish this. This is a mess. Like he needs
Hard.
support. This is super hard. But, oddly enough, we're almost there. And
That's great.
what's really helped is the physical prompting, to do leg over leg. So we tap sometimes the foot
Mhm.
that needs to move, so he remembers it. And and we do that in all kinds of PT and OT exercises that we're always using this little physical prompt to just, if he's not already doing it himself and he needs to get dressed, tap his leg if he needs to move his leg to push it by his pants.
Yes.
It's really worked wonders because I have to say our son is really profoundly disabled. Nothing comes naturally, so we have to do things a million times. No, no exaggeration here, for him to get the movement, and it's hard. Nobody can do something a million times, but
Yeah.
this
Hmm.
physical prompting is super helpful.
Yes.
What helped us with going up the stairs without using the handrail, he's not fully doing it, but he gets some physical prompts like holding his shirt up on both sides.
Yes.
And this has been a huge help with OT and the
Hmm.
fine motor skills because he's strengthening his core doing this on the stairs,
Hmm.
more able to do a little bit more with the getting dressed. And I was just wondering about the interplay between PT and OT, how these skills you see as helping kids to obtain fine motor skills later on, which are so difficult for many of our patients.
Yeah. Yes, it is very difficult for them. Um, because PTs focus more on the bigger muscle groups for that stability, I think it makes sense that that OT naturally almost like progresses after they kind of achieve that more stable posture or stability or balance. Because once they feel more secure, then they can think about smaller muscles that they have in their body. So whether it's ankles or fingers, So we always say gross motor before fine motor, but it doesn't mean that you have to wait until that gross motor is reached. We usually use more of the like a whole approach. So you're kind of like doing everything still and see what works the best. But I think the point is that you don't have to wait for the gross motor to be there first. But you may definitely see more increased progress after that new gross motor skills unlocked. I think that totally makes sense. And I think physical prompting, in a way, is really like a shortcut to their brain because when you're giving them a verbal instruction, they have to decode and process it in their brain, and then they have to know what it means. And we know the language part is not their strength, right? Right? Or with R, it's not. So when you're tapping that muscle directly, it is like a shortcut sensory input to your brain saying, oh, right, yes, I have a muscle there, and that's what I'm supposed to use right now. So it really works well, especially with kiddos who may be nonverbal or has communication challenges.
Excellent. And the other thing that we've been using is this balance board. So we had first the rectangular one, which is more easy. And now
Hmm.
we have the round one, which is super challenging. And this is another way to improve that core strength. That do you use those? Do you use
Yes.
the rectangular and the round?
Yes, I do. So that's actually, you bring up a good point. That's kind of coming from this like a different practice model. So essentially, when I'm challenging their balance so much that it is so hard for them. So if it's like a really unstable surface and I'm practicing standing with that much of a challenge, the goal is that once they're actually on the floor, which is an easier surface for them to work on than unstable wooden balance board or whatever, then the brain is going to think that, oh, wait, this is actually easier than this one, so I'm going to do better here. So coming from that really like hard setting to somehow easier setting kind of tricks the brain like, oh, like I can do this.
Yeah.
So yes, I do work on that a lot with my kids.
And RPT is sometimes like taking one foot off, or if you're on the ball,
Hmm.
changing the level, like so you're not always just using the surface below, but you're lifting your foot, and that activates a little bit more your core. There are so many things that
There
you
are
can
so many things.
do with not a lot of equipment, like
Mhm.
just a ball or just a mat, with different levels, or so the possibilities are endless. And
Yes.
I think
Hmm.
it's important to let folks know that, because a lot of times you try to buy all these different things, and it's really very basic. It's just really very basic things that you need to improve this core development. So,
Yeah. Well, I mean, okay, so I'm gonna move on to this thing. So kind of like you said, ball can do so much, but sometimes some kiddos have more spicy personality and they might not like anything, right? So like low motivation, it's always challenging and they just seem like they're not interested in anything like ball or like million other toys, whatever. And this closed loop activity is something that I find it really helpful, especially with kids who doesn't really seem like they're strongly motivated by something. And I would kind of recommend this more of a like a school age kids, may so maybe 3 plus. So like they when they're understanding the routine or like that they have like something that they have to follow, this works the best. So in a closed loop activities, so you're gonna start with setting up a chair. So it indicates a clear start. And then in the middle, you will put in an obstacle or any skill that you're working on. So on this photo, it's a step. It can be really anything. It can be it could be a crawling obstacle course, or it can be unstable surfaces rather than a step. And at the end, you will indicate a clear end to this loop by putting a cause and effect toy or anything that ends essentially to end the task. So for example, I would sit my daughter up in the chair and then I would hand her a ball. And then I would just without just telling her anything, like verbally prompting her anything, I would just take her hand, go up and down the steps, and then have her drop that ball from the start into the toy, and then that would kind of mark the end of the task. And then I do the same thing back, and then I sit her down again, and then I blow her bubble to kind of add in that reward, something that she prefers. And that reward can be anything, and like a music. I know our MEF2C kiddos love music or anything that they like. But bubbles, I find it more helpful because it ends quickly, and then you can get more reps in afterwards. And then you just kind of repeat this over and over and over. For us, who is neurotypical, this might seem very boring and can be really mundane to us without any like verbal cueing. It doesn't really feel like a play, but for them, this feels secure, right? It is repeated and it is very predictable for them to learn this new skill. So definitely, like I said before, use that physical gesture, that physical prompting, rather than telling them what to do. Just kind of go through back and forth. Yeah. And then once they do a better job at participating at that closed loop activities, and you see that they are gaining that physical progress with that skill that you're working on, it is really important that you take it to the next step. So go out to a different environment. A playground, great environment. The floor might be more unsteady, and there's other things like other kids running around. There's a lot more noises. So it's a different environment, and for them to practice that new skill at a different environment helps them to recreate that skill at a, you know, anywhere throughout their lives, right? And then timing, I also think is important. So if you're only working on this one skill, at 3 p.m. after they come back from school, they might get stuck in that routine. So it is really important that you kind of try to sprinkle that activity throughout their daily routine as well. Okay, so going on to the next session.
Oh,
There.
I just have a quick question that was
Mhm.
in the chat. So
Mhm.
Tanu asked a suggestion for kids who can't walk fast but still unable to run. And just, I mean, off the top of my head, something we do is like chasing something reinforcing like a kite, but you would likely have better insight than I would.
Yeah. Okay, so walking to running, it actually is a lot of steps, although it is just like a one little jump visually, but in the brain and like muscular level, a lot is happening. So for them to truly run, you have to achieve this what we call a double limb float phase. So your feet are essentially up in the air at the same time for a brief moment of time when they're running, truly running. In order to really achieve that, first, your ankle strength has to be good enough for push off from the ground. And then second, your balance has to be good enough to tolerate that single leg balance when they kind of land onto the ground and move on to running. So there's a lot of little things. So I mean, definitely talk to the therapist too, but you don't have to just work on running. I would work on more single leg balancing or hopping skills or, ankle stability exercises to kind of aid them to move on to the running stage. And of course, the running itself, you can also practice. You can take one hand with them and then practice running back and forth with that closed loop activity as well.
Thank
Hope
you.
that answered or hopefully was helpful.
Thank
Yeah. Um, I love the comments, but I can't see it right now because I'm presenting, but thank you, Anne, for bringing it up.
you.
Moving on to the therapy service types through IEP and 504 plan, which would be US specific. Um, So therapy service types, it can be delivered through IEP, the individual educational plan, or through 504 plan. So IEP more is from the IDEA law that is a federal law, and then 504 plan is more of a civil law. I won't go into too much detail, but the most important thing to note is that they both can provide relative services in a school setting. But I am guessing with MEF2C disorder, because it impacts so much different things in their educational setting. So 504 plan is more if they have a medical challenges or a physical impairment, and IEP is more encompassing that the whole educational plan. So if there's some educational delays, you are probably going to have an IEP. So most of the MEF-D kiddos, I'm assuming, will have an IEP. So when it comes to service, it can be direct versus indirect. And when it's direct, it really means that a therapist is seeing your child directly. So whether it is in an integrated setting, in their classroom or in their recess, or in a non-integrated setting, meaning they will probably pull out your kids into more smaller setting or without any other peers in that setting to really focus on the skill that they're working on without distraction. And sometimes it can be direct and indirect, or just direct, or just indirect, depending on what you're working on. Okay, so making the most out of your child's IEP, and this is some tips to advocate for your child's needs. So first of all, if you have an IEP, it's important to know that there may be a guideline for a school district, and this guideline can look different between other districts, right? But essentially, there is no one rule or law on what they're supposed to look like. So if the administration or the IEP team is saying something like, oh, this is always the way that we do it, that is probably a red flag to say that, because there really is no law and it's supposed to be an individualized educational plan. It is supposed to be what is best for your child. So let's maybe go over some phrases that you may have heard from the past IEP meetings or other conversations that you may have had with the school staff. So first, you may have heard, we are decreasing his direct minute goals because he met his goal. And again, all these comments, I've also said myself, they're not something that is inherently bad, but I feel like the parents can maybe ask a lot more follow-up questions to really understand why this is happening. And maybe there are some room for you to, advocate for your child's needs more. So when someone says they're decreasing a direct minutes because they met the goal, I think the follow-up question that you should ask is that, then what goal are we working on next? Why is it decreasing minutes? Meaning it's assuming that goal will be met with less minutes, right? With less work. So why are we choosing that goal to work on? Can we maybe find a new goal that is more challenging and attainable for your child? And someone may have said, we're moving her PT to consultative only model because the improvements we've seen that have plateaued, meaning that we are not making meaningful gains anymore. Really, this kind of makes me mad because plateaued in an educational setting can look very different, right? They're not the doctors, even if they've been working on the same goal for 3 years, even if they have not met the goal, slow progress still is a progress, right? So, and with the MEF2C kiddos, we know that some kids are learning how to walk at 7 or 8. We know that progress is slow. We know that they need millions of repetitions to really gain that skill. So, if they're trying to disregard the progress, even if it's a really tiny bits of progress, you have to kind of speak up that they are still making gains and maybe it's more time that they need rather than moving into the consultative model. Another comment is that we are decreasing her direct minutes because she has poor attention span. So 30 minutes is just too long. Simple solution to this can be, well, then can we split up a session? Can we do two 15-minute sessions rather than one long 30-minute session? So, and therapists, depending on the district, may not guarantee that, but they certainly can try. Another thing is that we would like to remove his one-on-one paraprofessional time for this class or transition because he has been doing so well. Again, it's not always a bad thing. I recommend this all the time, I feel like during the IEP meeting, but it may provide opportunity for independence for your child to practice. So, I mean, obviously you have to be careful about it. If it's a safety concern, then yeah, you have to speak up for that session. But if they are walking pretty well and is following routine well, maybe they don't need that one-on-one support during the transition or a PE or a recess, it may allow them a little more freedom to interact with other peers as well. And I see your hand.
Yes. So over the course of 13 years, I've heard several excuses from the school.
Yes.
One which I'm really unhappy with is that, and that I do not accept, is that, look, they're not doing it. I can't get them to do it. They're unable to do it. Our patients are generally on the autistic spectrum. It is difficult, to do things that are difficult, and you need an incentive. So
Yes.
schools need to have this behavioral support framework.
Mhm.
They should have an ABA on staff. Most of them don't. But that's not an acceptable excuse. You need to tell them, well, you need to find a behavioral consultant to help you accomplish that task because they will do it. And our son is particularly stubborn, but he's now drinking out of a cup and he never would accept the cup before. And we had an OT for 9 months who was telling us, oh, I'm sorry, he won't do it. And then someone worked with him for 1 month using the ABA methodology, and he did it. So, not acceptable excuse. And then another thing that I've heard over the years is the school is not responsible for this. This is not a school-based activity. Sorry. Navigating the school building, navigating the playground, self-care tasks are things that typical students do in school. That is not an acceptable excuse. And it
Absolutely.
doesn't
Hmm.
apply. So I mean, after so many years of talking about this in meetings, I start to say things, oh, this doesn't fly. But I have to say, I get a ton of services. So I get about five of each because Liam needs that. And it's only because I bring up these points all the time. And they can't argue with me because I'm right. You know, there are there is a behavioral structure. A lot of schools don't have it.
Hmm.
Have someone full time helping. What the main issue here is that teaching profoundly disabled students, it's one of the hardest tasks you can do. So
Yeah.
you need very well-trained people to do these tasks, and oftentimes you're not getting that. So, yeah, you really have to keep at it and look for the flaws in what they're doing.
Yes. I see another hand.
Hi, I'm a physical therapist. I can't change my name because it's my husband's account, but my name's Stephanie.
I see.
And another thing that I'd encourage parents to do is like, if you don't feel like the school district is giving your child the best program that they can give them, you can ask to look at other programs outside of the district. Like that is a right that you have too. So I know a lot of families don't know this, and I work for, agencies and I work for schools, but I always, the child comes first. So I'm a very big parent advocate, even though in meetings I can't be, but to families I can. And I say, like, if you feel like your child is not getting what they need, ask for, what else they can offer, because that is your right as a parent and a tax paying, person in that district. So, um, and then as Anne brought up, that medical versus school-based model, I hear that a lot too from school
Hmm.
districts. Like this child, and I've had CSE chair people say to me, "Look, the play like recess isn't, we don't care what they do on the playground." And I'm like, but that's part of their school day. Like just because they're not in a classroom doesn't mean that that doesn't count. I think PTs get like a lot of pushback, especially in school districts, because oh, well, they can walk up and down the stairs. Who cares if they're, how they're doing it, but they can do it. Then that's done, and your providers, definitely should have your child's best interest at heart.
Yes, I absolutely agree. Um, Sorry, my Chrome just froze and then it closed itself. So I'm gonna pull up my presentation. I only have two slides left, but bring up the great points. And another thing that I also hear a lot while my thing is loading here is that sometimes they'll try to move onto the consultative model because oh, they already have all the help that they need. They already have a one-on-one paraprofessional. They can help them to work on specific things. Well, if it's like walking or PT specific things, only physical therapists can help with those goals. So a paraprofessional is really only, supposed to help with certain things, and them writing their name or transitioning. If there is a gross motor skill involved or a specific skill involved, a professional definitely can help better than the one-on-one paraprofessional. So that alone is not a reason to move on to the consultative model at all. Yep. Okay. Mine is loaded. Let's see if I can share it again. All right, so this is actually my last slide here. So as a parent and guardian, some of the things that actually we actually already talked about, but know that you're a really important part of this decision-making process in the IEP meeting. I know as a clinician, I've been to hundreds of different IEP meetings, but I just had a meeting for my daughter's 6 months progress meeting for her early intervention things. And as a parent, it just feels totally different. I was actually nervous. So I know that it can be really nerve-wracking, but you have to understand that your voice actually matters in these meetings, even though it is really intimidating. So yeah, really understand that you need to advocate for your child and for a diagnosis specific practice. Kind of like I said before, some kids learn how to walk at 7 or 8. We know that with MEF2C disorder, it is a neurodevelopmental disorder. So things are going to look slower and the progress is going to look, not as fast as maybe they would like to see. But we know that physically, it is hard for them to make the neuronal connections. So advocate for that. And really kind of closely track your child's progress at school by either report cards or you can reach out and ask for like a at-home communication system. So sometimes my students will have a notebook that kind of travels home and school weekly. And kind of if you have any concerns, kind of bring it up before the IEP meetings directly to the clinicians or the teachers, to have those ongoing conversations. And I'm sure the school tells you this, but when they tell you that revision can happen at any time, they really mean that it can happen at any time. You do not have to wait a full year to revise a goal or change the time and frequency. You can call a revision meeting at any time. They might say something like, oh, we want a little more data before we meet. So maybe like give us 4 or 6 weeks till we collect more data. That is, I think it's actually a good thing. So you can maybe wait for the data collection, but they can't really say like we're meeting till next year because that's when their IP is scheduled. Um, and I think another, as a PT, I do so much with this kid, so I kind of wish the parents ask more about like what is their day more like on a daily basis. So if they're using like stander or gait trainer or walker, ask them, or a wheelchair, ask them like how their day actually looks like with their adaptive equipment. So if they're using wheelchair all day, are they in the wheelchair all day? Or if Are they getting some out of wheelchair time for posturing, pressure relief? What kind of equipments they're specifically using during recess or PE? Or if they are using those equipments, are they still able to participate well with other kids? Is there inclusive environment in that setting? So those are all the things that I think I would like to check if I'm a parent in a school setting. So yeah, that brings us to the final slide. If you guys have any more questions, feel free to raise your hand or comment. Uh,
Um, Stella, there was a question in the
yeah.
chat that
Mhm.
she had to leave, but asked if you would approach tips for using the walker. And maybe
Yeah.
since this is being recorded, she can come back and listen later. But she includes that my son's almost 7, huge improvements in walking in the last 3 months after starting again with horse riding therapy. But specifically what she asked was tips for using the walker.
Yeah. Um, I wonder if her child is just like having trouble just accessing the walker, question mark. So if they don't have that floor to stay and transfer yet, it is going to be maybe hard to access the walker by the child himself. Or, like if it is around them, it is in an accessible spot for the child to access it. Or, I mean, there's so many things that you can help a child use a walker. Are they using appropriate accessories, or is it really specialized to your child? Like, you can adjust a lot of settings, and there are a lot more accessories that you can add on to the walker, such as like a hip guide, things like that. So I would look into those too. And if, sometimes they will just prefer crawling versus walking, which is what I'm also dealing with right now. I think continue like building that environment where they don't feel like they're being forced into working is really important. Rather than like we're working, like this is what we're doing, maybe come from a maybe a little more play-based approach where you're smiling and there's music and bubbles, like this is fun, we're doing this is actually part of our play. I know setting up that environment is really hard when the child is refusing it, but that continuous work of kind of like creating the happy environment while they're walking can kind of encourage them to kind of return to that setting a little more. But yeah, there's a lot. Maybe she can email me, mess me in little more detail, and then I'll be able to help out in, with more insight.
Okay, I'll throw one in for about the walker.
Yeah.
Changing terrain,
Yes.
like when when the coming out of our garage to the driveway, there's just a small little lift in the pavement, or well,
Mhm.
actually, it's just like a step down, very small, not like a whole step. Uh, but that kind of makes my daughter nervous. Plus, going from smooth to
Yeah.
rough.
Sometimes visual cueing can really be helpful for some of my kids. Sometimes when there's a little curve or change in surface, I will bring in this like a bright green or yellow highlighted like tape, and then I would mark that change of terrain on the floor. And for kiddos who is using the walker, and I know that with MEF2C, a lot of the kids will have CBI as well. So having that really like visual marker for them to understand, oh, that's where it is, rather than them kind of like going down that obstacle blindfolded, can be really helpful to them to kind of motor plan beforehand, like, oh, I see where the obstacle is. This is what I'm going to do. I'm going to slow down, maybe lift up my walker over that thing, and then I'm gonna step over the obstacle. It's a small thing, but it can be helpful. Another thing is that if she is not feeling that confident about stepping over any kind of things, you can kind of try to recreate that environment in a home, like a safe setting. Something that I like to do is like if you have a yoga mat, you can throw a bunch of little objects underneath the yoga mat to make the bumpy road, and then have her kind of practice walk over it in that closed loop model. So she just like in that predictable, repetitive setting, she is practicing it and is gaining confidence. So hopefully after those practice, she will feel confident enough to apply that skill into your little garage situation there.
Yeah, that's good help. Thank you, because it can apply to other situations too, not just with the walker, but when I'm guiding her, holding her hand,
Yeah.
going over a threshold at the store is like panic. But so
Yeah.
what you just said will help apply
Yeah.
other
Hmm.
situations as well.
Yeah. And
Thank
I'm sure you're already doing it well, but motor planning can take a long time for kiddos with neurodevelopmental disorder. So even if they look stuck, they might be actively planning in their head, like, okay, what do I do next? So just give them enough time to react to that obstacle before you kind of jump in with that assistance. Yeah. Yeah, I think that's it.
Yeah. Thank you, Stella. This was extremely insightful. We'll let you know if we have any follow-up questions
Hmm.
and pass along your contact details.
Yeah, feel free to reach out to me with anything. Happy to help.
Super.
Awesome.
thank you.
Thank you all for joining us and enjoy the rest of Saturday.
Thank you all.
Thanks. Bye-bye.
Bye bye.